Okay, in the interest of time, I will go ahead and get started. So again, thank you for joining us on our second lecture series, Foundations Curriculum lecture series of 2023. It is my pleasure to introduce our speaker and to get us going. So just a couple of housekeeping items prior to that. All of you panelists, so all of you learners, you have the ability to unmute yourself and to start your video. So please feel free, if you're asking questions, to go ahead and do that. And our speaker can let you know if they want to do that in the during the lecture or at the end. But once you have that ability, you can just ask your questions. You don't have to put them in the chat box or the Q&A. And for all of the other viewers, you don't have that option. So please put any questions that you would like addressed to our speaker in the Q&A box. The chat box sometimes gets full of lots of other things, and so some of those questions can get missed. So just remember, the Q&A box would be a lot easier for us to keep track of any of those questions so that we can get them answered for you. And for our panelists, for the learners, please make sure that when you're not actively asking a question to please keep yourself muted so we don't have distractions for our speakers. So let's get started. Dr. Audrey Hébert is a clinical assistant professor of pediatrics in the Division of Neonatology at Laval University and a staff neonatologist at CHU de Quebec. She completed her pediatrics residency training in neonatal perinatal fellowship at University Laval in Quebec and formal training in neonatal hemodynamics and T&E at BC Women's Hospital and at the Hospital for Sick Children in Toronto. She obtained her master's degree in health sciences at the University of British Columbia, and she's developing her research interest in the field of chronic pulmonary hypertension associated with bronchopulmonary dysplasia, and then also training program development in T&E where she's at. So thank you so much for joining us, and I will stop sharing and turn the platform over to you.
All right, thank you. Let me just share my screen. All right. Great. So thank you so much, Danielle, for the introduction, and thank you for the invitation to be presenting today on chronic pulmonary hypertension. As I just mentioned briefly, disclosure, I've been sick and recovering from laryngitis, so hopefully my voice stays for the entire presentation. So I apologize if my voice sounds a bit weird today. So I have no conflict of interest to disclose. So really happy today to be talking about chronic pulmonary hypertension. As Danielle mentioned, this is kind of a topic for me that has been very interesting and sort of doing my research into that more specific field of hemodynamics. So hopefully by the end of today, we will have discussed obviously physiopathology and risk factor for developing chronic pulmonary hypertension. And we'll really talk more about screening and management of that disease. And we'll talk a little bit about the long-term impact and why it's so important to screen for pulmonary vascular disease in preterm infants, but also later in life. And my own personal objective is to hopefully make chronic pulmonary hypertension as interesting as acute PH, because I mean, I remember as a fellow and still now as a staff, obviously it's very fun to do the acute PH scan, and then you do the management and patient improves and you save the day and patient might not be going on ECMO and everyone's really happy. And then you fall into the chronic PH, which is, I mean, it says it's chronic, so it's not as maybe acute. Sometimes babies are harder to scan. You have to do this whole ritual for to get the image, like baby needs to be quiet, pacifier, mom needs to be singing the right song, like holding hands. And so I know it's not maybe as exciting, but hopefully you will be convinced that it's still a very important topic by the end of my presentation. Hopefully that's my goal. So jumping into the topic, and I'm not going to spend a lot of time on that because obviously we all know this as neonatologists, but BPD is really an interruption in the normal development of pulmonary structures. And in those structures, well, we know that there's a lot of vasculature, and that's what we're going to be talking about today. And physiopathology for BPD is very much multifactorial. So there's many things that we can have an impact on, but there's other things that are pretty much out of our control. So there's genetics factors, environmental factors, maternal factors that may lead to development of BPD and severity of BPD also. And that leads to not only abnormal alveolarization, but also vascular development. And so we know that we've been actually quite good, and these are Canadian data from CNN, so from Canadian Neonatal Network, and we've been really good in the past decade as improving survival, and not only improving survival in kind of older gestational age, but also in younger ones. And now, so we hear very often now talking about 22 weekers, which we really didn't even like 10 years ago. But we haven't been so good at chronic lung disease, and incidence has been quite stable. As much as survival improved, chronic lung disease hasn't improved as much. And we know that in the population of, those very tiny babies, the less than 25 weeker, so that's the graph right here. We know that chronic lung disease is actually quite common. And not only it's common, but the severe or the moderate to severe chronic lung disease is really the majority of these patients. And these are the ones, as we see today, that are at risk for chronic pulmonary hypertension. So pulmonary hypertension and BPD, if we look at the immature lungs, as you know, they're going to have many hits during their NICU stay. So there's going to be lungs damaged, especially because the patient will be exposed to ventilation, oxygen, and the free radicals. You will have many things that will create inflammation, so infections, the ventilator, and then you have growth that is suboptimal. As much as we try to reproduce nutrition, it's obviously not the same as being in the womb. So a lot of these patients will suffer from suboptimal growth. And then they're also exposed to medication that will have an impact on lung development, such as postnatal steroids. NSAIDs has been, having a bit of a bad press lately on lung development. So these are all things that will lead to not only BPD, but will also have an impact on vasculature development. And I really like this picture actually coming from this paper from 2017, as that kind of like, there's things that happen during pregnancy and then birth, and then everything that happens that can lead to BPD development. And so as I was mentioning, it's not only the lung, but it's also at the vascular level that things will happen and really just kind of make growth stop. The vasculature growth stops. So you now have fewer pulmonary blood vessels, really. And you not only have fewer blood vessels, but those blood vessels, you have abnormal vascular growth, you have remodeling happening, you have hypertrophy, and then that leads to increased vascular resistance. And that also leads to that kind of ventilation perfusion mismatch. So these are all really much biological reasons to developing pulmonary hypertension in patients that have BPD. So pulmonary hypertension in BPD, when we look at the incidence, so there was a meta-analysis that was published in 2017, and really what they stated is that 17% in overall BPD, if you look at all the BPD patients, overall incidence was around 17%. And what was interesting coming from that paper is that not only it was obviously more often we had pulmonary hypertension in moderate to severe BPD, so almost 25%, but they also found BPD in patients also had pulmonary hypertension in patients that had really, mild to no BPD. That was around 10%. So really all our premature infants might be at risk. And obviously the more severe your BPD is, the more at risk you are of developing pulmonary hypertension. And why it's important, but these patients actually will be at increased risk of not only morbidities, but also mortality. So the risk of mortality actually increases up to 35% at 6 months if you have pulmonary hypertension associated with your BPD. So it's really a disease that is important to screen for and obviously manage, and we'll talk about that today. All right, controversial slide coming ahead. If you are somehow on Twitter a little bit, you know there's going to be a lot of debate about my next slide, but I thought it was important to talk about it today. So if you don't agree, then I'm happy to talk about it during the Q&A question. So what are the risk factors for chronic pulmonary hypertension associated with BPD? Of course, as I mentioned already, gestational age and birth weight, you know, this is probably the main risk factor. So the earlier that you're born, the smaller that you are at birth, the more at risk you are of developing chronic pulmonary hypertension. IUGR patients are very much a population that are really much at risk and that we should really be looking at more closely at 36 weeks, because we know that these patients usually have very much abnormal vasculature development due to their IUGR. So they're not only at risk of acute PH, but they're also more at risk of chronic PH. Patients that are born with oligo, whatever the reasons are, because of PROM are more at risk. And we know from one study that the patients that show early signs actually, and that study show that at day 7, if you had signs of pulmonary hypertension, then you were, or pulmonary vascular disease, should I say, you were more at risk of having pulmonary hypertension at 36 weeks. So when the BPD diagnosis was made. And this is where the controversy might be, PDA. So duration of shunt exposure, it is not an outcome that is often looked at. And I will take a few minutes after to kind of discuss this risk factor a bit more closely. But not a lot of the RCTs, and we've had great RCTs published in the past year or so. Unfortunately, this outcome hasn't been really looked at, but we know from the pediatric literature that, you know, shunt exposure and having overcirculation at your pulmonary overcirculation, that is a risk factor for developing pulmonary hypertension. So you can imagine that in a baby that is a preterm baby developing lungs, being exposed, maybe not for 7 or a few days, but being exposed chronically for a few weeks or even a few months to this kind of large left to right shunt might be detrimental. I know, controversial, but we have this great paper. So this was actually published just at the end of 2022, and this is coming from Alabama. So they looked at 138 patients with BPD alone, and then 82 infants that had BPD with pulmonary hypertension. And what they found is that the more exposure you had, the longer exposure you had to a PDA, and then also they looked at moderate to large PDA, the more at risk you were of developing pulmonary hypertension associated with your BPD at discharge. And when they look, and this is what this graph is showing, so A is BPD and PDA, sorry, and then this one is moderate to severe PDA. So for each additional month of PDA and hemodynamically significant PDA exposure, your increased probability of composite outcome of BPD and PH and at discharge or death. So, I mean, this was a pretty convincing study for me. Obviously, it comes from one center, and this is from the same study, kind of similar. Just this, it's a table instead of the figure, but so similar data, but really when you look at this kind of PDA exposure by weeks, so PDA or significant PDA, the odds ratio, and this is significant, really increases, and the more you go into, the further along you are exposed to your PDA, the more at risk you become of developing pulmonary hypertension. And then this is actually not published yet, so it's submitted and hopefully it will get published. So we actually looked at 2 centers in Quebec that have a different approach to PDA treatment. So one center has a conservative approach and one has a interventional approach. And we look at our echoes at 36 weeks, and we don't have echoes prior to the 36 weeks. So we don't know the impact really of like how much of these patients really had a PDA exposure, but we know that the interventional group had pretty much 80% of PDA treatment. As the conservative group, it was actually 0%. And what we found is that we actually didn't have a statistically significant difference in pulmonary hypertension, but the group that was exposed to conservative treatment had still higher systemic pulmonary pressure at 36 weeks, of almost reaching the pulmonary hypertension definition compared to the group to interventional, and that was significant. So we know that being kind of exposed to the PDA might actually be a risk factor for developing pulmonary hypertension. So I rest my case for the PDA part, but I mean, I thought it was important to talk about it. And I think that's an outcome. If you want to do research in PDA, that's great, but please think about maybe having that outcome for chronic pulmonary hypertension in the things that you look at, because I think it's an important one that is not often included, unfortunately, in the studies. So jumping into kind of the screening, we're going to be talking about really screening at large. Who do we screen? When should we screen? And how, especially how do we screen? So talking about the when do screen, there's actually the American Heart Association published in 2015 guidelines that included our population of bronchopulmonary dysplasia. And what they said is that, these patients should be screened by echo when you establish diagnosis of BPD. So pretty much at 36 weeks. And then in 2017, the PPHNet group came out with guidelines of evaluation and management of pulmonary hypertension in patients that had BPD. And they also suggested that, or they recommended that at the time of formal BPD diagnosis, we do a assessment by echo to screen for pulmonary hypertension. So really, I think the when to screen, I would say that most and there's also European guidelines, which I'm sorry, I should have included, but they also recommend that we do screening at 36 weeks. So who do we screen? Well, that part I think is a bit more, there's no consensus, and usually it's not much included actually in the guidelines. The European guidelines do suggest that we should screen for patients that are born in gestational at less than 28 weeks. But really there's no formal consensus. The American Heart Association and PPHNet don't go into kind of like the strict recommendation of who should we screen. So I don't really have the answer. And what we did locally actually is that we used to have a kind of local guidelines for screening for BPD. And then the province of Quebec, there's actually 6 NICUs. And then we decided to come with kind of a provincial BPD screening for pulmonary hypertension that would be the same used across the 6 centers. And then when we sat down, we realized that none of us had actually the same cutoff as to who we were screening. So then we said, well, let's just ask around and our centers in Canada. And I know Iowa is not in Canada, but they're included in our little homemade survey. And so this is really just, coming from emails, and this is not something done very scientifically, but when we asked, and it was kind of surprising to see that none of the centers we asked actually had the same criteria. So really, I don't have the answer. I think that it's just important to, one, screen and kind of decide locally, like, should you be screening less than 28 weeks? And the patient, I think the patients that are important to consider, as I mentioned already, is IUGR patient, and also patients that might be older than the 28 or 27 cutoff. But then if they're not evolving or still need respiratory support or oxygen support at 36 weeks, then maybe this patient should be screened for pulmonary hypertension. And I just wanted to mention that Iowa, because as to the when, so usually screening will be done at 36 weeks. I thought they had an interesting approach, and I think it makes sense, just because we have really younger population now. So the baby that is born at 27 plus 6, you know, if you do the echo around 8 weeks or around 36 weeks, patient's not going to be that old, which it's fine, right? But if you have a patient that is born at 22 weeks, and you start screening at 36 weeks, that's a pretty long delay. So they actually will do kind of the 8 weeks cutoff. So that's their practice locally. I just wanted to mention it because it's not in the guidelines, but I think that these really, really tiny preemies that are born at the 22, 23, even 24 week mark might be screened earlier. So something to consider. Okay, so how to screen? I think this is really the main, the main focus of the presentation, obviously coming for fellows who are interested in echo. And then, so we do have guidelines. There's a few protocol that are published out there, and this is coming from a paper from Phil Livy in Boston. And what they recommended is that, you know, at 36 weeks, what we should include in our echo is really, well, assessment of the elevated RV afterload. So size, shape, the relationship between the two ventricles, looking at the septum, and then an estimation of pulmonary hemodynamics and RV systolic pressure, and then look at RV morphology and function. And then when we look at what the PPH-NET group suggested in their guidelines, really was kind of a complete echo for patients, and then you should have a complete anatomic evaluation. These patients most likely will have echoes in their lifetime, so it's rarely happens that the first echo would be at 36 weeks, but if it happens, and I think it's important to have, you know, a full anatomy and make sure that the anatomy is normal, and especially assess for shunts. And then you look at the right and left ventricular size, you look for hypertrophy, you look for function, and then septal position, as we mentioned, tricuspid, pulmonary regurgitation, and then importantly, and then they added it, and I think it's important to look at systemic blood pressure at the same time as we do the echo. So this is kind of what the recommendation looks like. And I especially like the tables that they included, and it's very similar to what we do in terms of protocol. And it's really, I mean, it's pretty a full echo. There's a lot of focus on the RV, which is important, obviously, when we talk about chronic pulmonary hypertension, but we will talk a little bit about the LV also, and actually the LA too. And they've included that it's important to talk about the left side, even if our main focus is the right side. So again, and then I'll show you some images and pictures after this, but looking at the RV size, looking at the septal position, again, TR jet, if you have shunts, the left side. And then the other thing that's really important is not only, I mean, it's okay to look at the qualitative assessment and look, you know, does the function look normal? Does the size look normal? But really, we need to have objective measures. And it's particularly important, I think, in these patients, because most likely you'll do follow-up echoes on these patients. And it's important to have objective measures at the time of the echo, but also in order to compare in time, is the patient improving, deteriorating? So just being a qualitative assessment is not enough. And we know that we're not really good at assessing qualitatively. So it's important to have these objective measures. So TAPSE is a big one, RV fraction area change. In that table, they do it in the 4-chamber, which is fine. It's been studied. I'll show you, I personally like to do it in the RV 3-chamber modified view. So I'll show you a clip of that. And then the RV over LV ratio. So you usually want it to be less than 1 to be normal. And then tissue Doppler can be done. They didn't include strain. I personally don't do strain on clinical basis, especially on the RV, but I think it's really interesting for the research and hopefully we'll get there with the clinical. And I think it's fine if you do it in your center, that's great, but usually more used in research. So this is kind of like looking at this. I mean, this is obviously a short axis, and when you look at this view, it's pretty easy to assess the septum, and pretty easy here to see that the septum, I mean, the motion of the septum it's not normal. So you want to look at it in the end systole and see if it's either round, flat, or paradoxal. And we'll talk about the eccentricity index a little bit later, because this is really more of a me looking at it and saying, well, this isn't, when it's paradoxal and it's really normal and round, and I think everyone agrees, but it's when it's flat that sometimes it's a bit. So the eccentricity index, what we'll talk about, is really some kind of an objective measure for that septum. And then you can look at, you can do the RV over LV ratio on that on that view in the M modal also. So this is a TAPSE. I think all of you will be most likely familiar with this. So we do it usually in the 4-chamber view. It's important to have your angle right. And this is one of the measures that has been the most studies. It actually has been associated also, if you have abnormal TAPSE, to actually at 36 weeks to increase mortality risk. So this one is one that we always obtain. And as I said, it's important in terms of when you follow up with these patients. And then shunt. So these patients usually at 36 weeks, most likely will have their PDA closed at that time. Sometimes you might have a PDA. So important to look at the direction of the flow, but usually they'll have still a PFO. So that's usually where we can assess direction of the flow. So this one is pretty obvious that it's not normal and it's right to left. You can obviously put a Doppler through that and make sure that you assess the flow direction. And that, sorry, this is in French because these are mine. So my echo machine is actually in French. But so this one is not talked about a lot in the guidelines, but this is one that I find really important to do. So this is the RVET over PAAT ratio. So the right ventricular acceleration time over the pulmonary artery acceleration time. So ejection time over the pulmonary artery acceleration. Sorry, again, saying it in English instead of French. So really, you do it in the pulmonary artery, and this is a really good measure. So if your pulmonary acceleration time is really quick, it's really short, that is actually usually a sign of increased pulmonary vascular resistance. And I find that doing these echoes, it's usually the first sign that we'll have of abnormal or a sign of pulmonary vascular disease. So you often get this abnormal ratio when even before pulmonary hypertension really happens. And sometimes it's the only sign that you'll have. And these are tricky and we don't really always know what to do. We usually follow them. But I think this one is one that is an easy measure to do. It's a reliable measure. And it's usually the first sign that we have of pulmonary vascular disease. And also the shape actually of the Doppler, it can be telling. So usually if your pulmonary artery acceleration time is really short, like on this image, you will have, instead of having kind of and this is Dr. McNair, he liked that question when I was a fellow. I don't know if he still asks, but the triangle. So you usually have an isocell triangle if it's normal, and you have that right angle. So, and then you might have even like this one, a bit of a notch in your Doppler. So this is really, as I said, sometimes it's kind of the first sign of pulmonary vascular disease. And then you can do a Doppler in the tricuspid. So if you have a nice regurgitation like this one, then you're lucky and you can do an estimated of your RV pressure. And if not, you can sometimes have pulmonary insufficiency. So you can also kind of estimate your mean pulmonary artery pressure. So that goes into kind of going into what's pulmonary hypertension and what's the definition. So really, this is kind of the one that is accepted in the literature, not only in neonatal, but also pediatric and adult. So a mean pulmonary artery pressure above 20. It used to be 25. It was changed a few years ago to 20. So you can either estimate it, well, measure it by CAT or estimate it by echo, or a systolic RV pressure above 40. So these are kind of the two measures that you'll see really in the literature. There's one and we'll talk about the challenges in the neonate about this definition. So this one is the eccentricity index is not really one that we see often. It's one that we like to use locally because, you know, the eccentricity index it's an easy measure to do and it's reliable. So if it's above 1, usually we'll say it's abnormal. And in the literature, if it's really above 1.3, then it usually is associated with pulmonary hypertension. And this table comes from, again, the PPHNet guidelines, but they kind of stratify the severity. So is it mild, moderate, or severe PH? And that really depends on your measure of RV systolic pressure on your systemic pressure. And then your septal position in systole. Do you have RV hypertrophy or dilatation, and your RV function? So this is really the definition that is used in the literature. I've seen other, you know, sometimes in papers, people will use your RV over LV ratio. Sometimes they'll use shunt direction. So you can obviously add a bunch of abnormal findings at your echo, but really these two ones are really the ones that are kind of the official ones from the literature, not only in neonates, but pediatric and adults. So I did mention eccentricity index. I just wanted to add these two pictures just for people that might not be so familiar with that measure. So eccentricity index, as I said, you do it in the short axis, you do it in systole, and it's really just, and you do it at the papillary muscle level, and it's really a measure of an objective measure of your septum. So as I mentioned, when it's really nicely round, the measure, so you do the horizontal over vertical line, and then you should have less than 1 being normal. And when you have a flat septum or even paradoxal septum, well, it's pretty easy to see that your horizontal line will be, you know, wider. And when you do your kind of ratio of that line over this line, then usually your eccentricity index will be higher than 1, being abnormal. So it's a fairly easy measure. And then you can also do your RV over LV ratio in that same image. So challenges in neonates. For the echo, well, for doing the diagnosis of pulmonary hypertension on echo, well, in neonates, you often don't have a TR jet, so it's usually absent or inconsistent. You might not have that nice full envelope to do your measurement. So that's a challenge. And in the literature, sometimes it's, you know, 10% of the neonates had a TR jet. So really that's one of the major, because if you don't have a TR jet, then you can't really do your RV pressure. If you have PI, then you might be able to do mean pulmonary artery measurements. But again, it's not always the case. You don't always have a nice envelope either. Assessing RV function also is a limitation, because we know that the shape of the RV is it's not like the LV. It's a unique shape. There's a lot of trabeculation, so that's also can be challenging. And this is kind of an example of an RV modified RV3 chamber. So you have the RA and RV, and then you have here your tricuspid valve, and then pulmonary valve, pulmonary artery going in. So this, and just personally, I find that this is where I usually find the best. If there's TR, then that's usually where I will have the best envelope. And I think we can all agree that if we look at this image, that, you know, qualitatively, this is not a normal RV. This is a dilated RV. This is a function is not normal, but really in that view, then I find it easier to trace that systole and diastole to get your RV fraction area change measurement. So personally, this is where I do it. And then the other challenge that we face sometimes in that population, especially at 36 weeks, is the systemic hypertension. So these patients usually tend to have kind of a higher, not all of them, but it's not rare that we'll have patients that might have a blood pressure, systolic blood pressure around in the 90s, which is not something that you will treat, but I mean, it's still high. So when you want to do your pulmonary pressure over your systemic pressure, well, if the patient is hypertensive, that's kind of an issue, right? So it's important to note that systemic hypertension, and then same thing, right? If you're looking at that short axis that I can go back to that image, but you can find that if, your LV, your patient is hypertensive and you have a pressure of 95, well, in order for your septum to be flat, your RV will have to have a very high pressure to kind of go onto like a flat septum for an LV that has high pressure. So that's something that is not talked a lot about, I find, in the literature, but it's something that clinically we do see quite often. And it's a challenge, I think, in neonates. So we talk a lot about the RV, but I think it's important that we also spend a little bit of time on the LV. So left side, well, you can have left ventricular diastolic dysfunction, and we'll talk a little bit about the left atrial hypertension. So we know that actually these, the two ventricles, they're the dense partners. They work together. And when this is a paper that came out from the McGill group, but what they did is that they looked at their patient that they were screening. And so less than 29 weeks, they had 78 patients, so 35% of their population had PH, which actually is quite high. And of these, 11% were qualified as being, moderate to severe PH. And so we've talked about this, but obviously the RV function was not normal. So TAPSE and RV fractional area change in the population that had PH were abnormal. Interestingly, though, they did strain analysis, and what they found is that not only the RV was abnormal, but also the LV. So really, there might be an alteration in the RV and LV function, and is it a consequence or is it the source of the disease? I don't think we have that answer, but I think it's important not to forget your left side when doing these echoes and assessment of patient. Because your left side might also be suffering. And this is a study that just came out in 2022 from the Stanford group. And what they did is that they looked at 34 patients who had pulmonary hypertension associated with BPD. And these patients underwent cath and at less than 2 years old. And what they found is really interesting, actually, is 33% of their patients had left atrial hypertension. And that's interesting because that's a post-capillary component. So if you're treating your patients with what we usually use, pulmonary vasodilation medications such as sildenafil, well, you might actually worsen your patient if they have left atrial hypertension. And it's really difficult to assess on echo. Usually it will be found during cath assessment. And the message is not, and we'll talk about cath, but I think it's just important that if you start a medication and your patient is deteriorating instead of improving, that could be an explanation and it needs to be assessed. So it's a really neat study coming from Stanford. So management, we talk a lot about the screening. So what happens when we do find pulmonary hypertension? So investigation and treatment of comorbidities is really important. Obviously, this is going to be more by maybe the primary care team, but as a hemodynamic consultant, I think it's important that we do look at what else can be affecting the patient. And I'm not saying that we need to do all of these investigation, but if your patient is deteriorating, you're finding worsening pH or worsening function on echo, then it's important that we assess the patient in its entire form. So these are kind of investigation that can be done in order to rule out other comorbidities. I'll talk about pulmonary vein stenosis a little bit later. And we did a survey a few years ago asking neonatologists with hemodynamic expertise. So we had 40 responders, but what they were doing in terms of alternative investigation in those patients when they were screening for pulmonary hypertension in BPD. And really what we see is it's very wide responses. I think a lot of people, I mean, most of them were doing at least a chest x-ray, but in terms of other investigations, not, the chest CT scan was not done very frequently, but I think they're just important to know that we can do these other assessments, especially if your patient is worsening or not evolving as you would expect. Management. So we'll talk about a treatment. So first line being diuretics. Pretty controversial. There's not a lot of literature on the topic, to be honest, in terms of pulmonary hypertension in BPD. I know diuretics have been used a lot in neonates before, and I think it can be interesting. Obviously, it's a first line of therapy for pediatric or adults, patients that would have signs of heart failure. So if your patient is showing the heart dysfunction, then I think diuretics do have a place. We do use it as a first-line therapy. I think if the patient is not responding, then maybe reassess, like any medications really. And I think just the risk and benefits, especially in the NICU population. So we know it's not really good for bone growth, for renal function as well. So just kind of, I think it has its place, but there's not a lot of literature on the topic. Oxygen therapy, obviously oxygen can be, should be used really in pulmonary hypertension. So the saturation limit should be, so in the literature, it's 92 to 95%. Some of the guidelines will say above 92% if your patient is at risk of PH. And if you have PH diagnosed, then you should aim for higher than 95%. Nitric, I'm not going to talk a lot about today. I think it can be used really if you do an echo and your patient is in pH crisis or have severe pH. I think nitric can be interesting as kind of a first start into this acute setting, but most likely then you'll go into something of a more chronic medication such as sildenafil. So we do use nitric sometimes if we consider sildenafil just to see the response to nitric, just because it's easy to use and it's especially easy to wean if the patient doesn't improve or if the patient worsen. So we sometimes do that before introducing sildenafil, but not all the time. And I thought this was this is coming from this Toronto group, and this is so they published this, and this is kind of their local protocol in terms of screening. But what I thought was interesting is it's really the only group that I've seen that I've actually introduced diuretic into their protocol. So really what they do is that they screen at 36 weeks if there are symptoms of congestive heart failure, and then there's right ventricular dilatation on echo, then they'll start diuretic therapy, and they actually use furosemide as first line. And then they'll repeat the echo, and if the patient is improving, then they'll continue diuretic therapy for 2 weeks. And then if the patient is improved, is off respiratory support, they'll stop it. If not, then they discharge home the patient with diuretics. So I thought it was pretty neat just to present and see what one of the group is doing. We actually do something very similar locally. But I know some centers who won't use diuretics. And as I said, there's not a lot of literature on the topic. Medical therapy, so pulmonary vasodilator should really be considered in patients that have chronic pulmonary hypertension if you have optimized your pulmonary and cardiac management. So if you have RV dysfunction, pulmonary hypertension, and you do not have pulmonary vein stenosis or LV dysfunction, then really you're probably you should be starting the therapy. So what are the medical therapy that we have? And obviously, depending where you're practicing, you might have different access to those medication. But I think the main one being sildenafil, I think that's the one we have the more experience with. That's usually our first line. Well, after oxygen diuretics, this is usually our first time in terms of pulmonary vasodilator. So sildenafil will be introduced. And then really, these are kind of more acute ones. So patient is obviously not going to go home if he's on milrinone, but these are kind of therapy that can be used. So the ones that we see more is the milrinone, as I said, nitric, and then iloprost we don't use a lot, but I've seen some report, not so much in that chronic pulmonary hypertension, but it could be used. And then I've seen actually a few patients really respond to treprostinil. But at that point, usually these are severe pulmonary hypertension. It's not going to be just us starting that. Usually at that point, cardiology or the pulmonary hypertension team is involved. But these are all therapy. And I think it's just important to remind ourselves of the pathways. So if you usually have three pathways. So you have the nitric oxide, you have the prostacyclin, and then you have endothelin pathway. So if you're going to be adding drugs, then it's important to kind of play on different pathways, because if you just keep adding drugs from the same pathway, usually you're not going to be really doing much. So just kind of important to remind ourselves of what drugs are being are acting on different pathways. So that's why I was saying that we might sometimes introduce nitric in first, and then if we see that there's a good response to nitric, then we'll usually do a relay to sildenafil. Cardiac cath. So cardiac cath, it remains the gold standard for diagnosis of PH. We don't like usually sending your patient cardiac cath. Our patients are usually very sick, the ones that need a cardiac cath anyways. They might be off the ventilator, and then you have to re-intubate those patients for the procedure. So, but I think cardiac cath, as much as we don't really like it, is important. So you can use it obviously to confirm your PH diagnosis, but I think sometimes it comes really into play when you want to evaluate the response to your pulmonary vasodilators. And if you're into first-line therapy and patient is not improving, and you're considering a second-line therapy, then really patient should probably go down to cardiac cath. Important also to assess shunt assessments. So sometimes the shunts might contribute more than we think to the pulmonary overcirculation. And as I mentioned, the LV diastolic function and even the LA hypertension can be very difficult to assess on echo. So I think this is a big one, especially if your patient is not responding to the therapy as he should be. So cardiac cath does have its role, and it remains a gold standard and really should be considered in some patients. Pulmonary vein stenosis, I'm not going to talk a lot about today because I know there was actually a full presentation on that, and it's a pretty big topic, but I needed to mention it because it can be a component. Again, if your patient is not improving or worsening, it's really important to look at pulmonary vein stenosis. We look at pulmonary veins on every screening echo that we do, starting at 36 weeks all the time. So we know there's a link between BPD prematurity and PVS. I think the difficulty is that PVS is rarely diagnosed at 36 weeks. So usually it will be diagnosed more towards even 4 to 6 months. So usually the patient might not still be in the NICU. He might still be in the NICU, but sometimes he might be discharged at home or follow up by not the neonatology team. So, but it's important. It's an entity that is important to know and to screen for. It's very difficult to treat and doesn't really have a good prognosis, but I mean, it needs to be screened for and detected if your patient has PVS. And then this is kind of just a wrap up of kind of a whole protocol, and this is coming from the PPHNet group of how they suggest screening patients depending on how severe BPD is and really what type of follow-up we need to do. So follow-up, really there is not, and I think that's where there's a lot of a knowledge gap in chronic pulmonary hypertension. I think that's a really big one. We don't really know, what the follow-up is and how long should we screen these patients for. And if the first echo is normal at 36 weeks, is it fine and patient goes home and we never hear about it? Or should we screen these patients once they are discharged? Should they have screening? I think really they should. We're actually starting a clinic for these patients at our center that I'm going to be involved with. So I know some centers have those clinics too, that we do follow our patients for pulmonary hypertension BPD. So these patients should really be followed up by a multidisciplinary team, especially obviously if they have PH, they need to follow up. But those BPD patients that will go home on oxygen should also probably be followed up for PH. So by the cardiology team, pulmonology team, and then obviously they need also OT, physio, nutrition, and speech therapy usually. And then why do we need to follow these patients? And I'm almost done, I'm seeing time, but so as I said, I think there's a big knowledge gap on how long, what's timing, frequency, and sometimes I think one of the biggest criticisms is in when we say, oh, we should follow these patients, people usually say, well, if the BPD improve with time, usually does it equal an improvement in chronic pulmonary hypertension? And the answer is most likely yes, but I think the best answer right now is we don't really know. And I think we need to be cautious with that population. And this is again from the team from Stanford, but these patients at 5 years follow-up, patient that did have pulmonary hypertension, I mean, there was a 28% mortality at 5-year follow-up. And 16 of these patients did develop pulmonary vein stenosis, which is actually really high, but it's just kind of proves the importance of following these patients. And we have more and more data coming from actually the adult world, and Dr. Goss did present last year, but she's been doing studies on patients ex-preterms that are now adults, and these are patients that were born in late 80s or early 90s, and they were 28 weeks, and they actually sent them to the cath lab, and surprisingly these patients there's 5 patients that did have the criteria for pulmonary hypertension, and when you look at the preterm compared to the term, these patients, these old ex-preemies were really at risk of developing pulmonary vascular disease as adults. And I love this figure from this paper of and I think as a neo, it's important not to only look at patients when you're in the NICU, but you want patients to not only survive but do well. And there's so many things that will happen during infancy and childhood that we don't really always have, unfortunately, a lot of control on our patients when they're out of NICU, but malnutrition, genetic profile, obesity, tobacco, and these things will impact not only obviously the patients, but these patients that already have an altered RV or LV performance, already have a pulmonary vascular disease. Well, these patients will grow up to be adults, and we know now that prematurity is really a risk factor for cardiovascular disease, and these patients will have systemic hypertension, but they also are at risk for pulmonary hypertension, and they need to be followed. And what I think is the big unknown right now is that these cohort were born 30 years ago, and the average was 28, 30 weeks. And what's going to happen for 22, 23 weekers that are now born? So these patients will need to be followed up and see in 25 or 30 years how they're doing cardiovascular. So I'm kind of running that. I want to have time for questions, and we can discuss. This is the case that I sent, but at this point, I think I'm just gonna go on and take questions, and we can discuss the case if you guys have questions about the case. Thank you.
Thank you so much for that that talk, Audrey. It's fantastic, and you really addressed so many things. So we really appreciate you coming and giving us that.